Right now, I'd like to introduce Antoine Craig.
Thank you very much, Chris, and welcome everyone. As Chris said, my name is Antoine Craig. So I'm not going to go into too much long talking because we're already a little bit behind, and you know what conferences are like, right? The first thing that we're going to do is I'm going to invite my dear friend Sheldon, who's sitting here, who represents the East Coast Two-Spirit Community or Society. And this is a Native American community. And we want to ask our ancestors for the permission to be here. Because some of us have been here and we take it for granted that we have a right here. So, Sheldon.
Sheldon Imachiapielo. My name is Sheldon Raymer, and I'm from the Cheyenne River Sioux tribe. I live here in New York City. I am the chair of the East Coast Two-Spirit Society. And just to give you a background on what we are, the East Coast Two-Spirit Society is devoted to Two-Spirit Native American and First Nations communities and the reduction of bias and discrimination due to lack of information. We provide information to the general public and support services to Two-Spirit natives, formerly known as lesbian, gay, bisexual, transgender, or gender non-conforming. East Coast Two-Spirit Society works to increase the positive visibility of Two-Spirit communities and providing safe, supportive opportunities for social, traditional, and recreational interactions that are culturally appropriate to them. East Coast Two-Spirit Society also strives to teach Two-Spirit youth and their families to provide emotional support, care, and community of people who have experienced the challenges of being Native and Two-Spirit, often while living or working in Native and other communities where they may not be fully welcomed or supported by others. Just a real quick history lesson. So before colonizers came to this land, in many different nations, there were people that were third, fourth, fifth, sixth genders. So to this land, in my Lakota language, the term would have been winkde for myself amongst my people. With this time, I want to just thank all the organizers in putting this together. It's an honor to be asked to be here to just to do an opening prayer. And so at this time, in your own way, Tunkashila Creator Wakantanka, we ask that you bless everyone here today in all their travels from where they came. We ask that we bless all the speakers that are going to share their knowledge, that we take it in, that we may bring this back to our communities and share the wealth of knowledge that will then impact and help others unite into the circle. In this way, all my relations, all my takoyasi. Thank you. Lastly, we're very giving people. This weekend, if you're in town, there is the Indigenous Peoples Day Native American Festival at Randall's Island. We are reclaiming this, instead of Columbus Day, as Indigenous Peoples Day. So this is history we're making right now. So we ask that you support us. There's flyers here. Thank you.
Our team that has helped to plan this conference, we come from different organizations, different people, and we thought that we'd like to really and truly welcome you, and each person who's part of the planning of the conference will share with you, their thoughts, what it was like putting this conference together. Among that sharing this welcome as well would be Denis Romero, who represents SAMHSA, the federal organization that looks at mental health. And so he is going to be representing the federal government and just giving a couple of words of welcome as well. It's been an unusual experience for me to put this conference together. Lots of challenges, lots of difficulties, and I'm sure that many of you know some of the problems that you encounter with people who make commitments and then don't follow through. And the frustrations that come with that. So there's lots of times when I've had to think outside of the box and think of other ways to get around doing something. But it was a bit of a relief to actually see the entire conference coming together, to see everything being pulled together, people finally waking up and realizing that yes, this is going to happen, and that yes, this is unprecedented, and yes, this is groundbreaking. And then everybody wanted to jump on board, right? And in a sense, it was kind of disappointing and angering, but on the other hand, it was like humbling to realize that even though they were skeptical, they finally came around and they kind of realized that this is something they want to be part of. But one of the most important things I think that really told me that this was happening is when all of you registered. That at least 2 weeks before today, we were sold out. Okay, so thank you very much for being here. Now, and I know they're probably going to wheel and squeal and get on and make a whole lot of noise, but where is the whole crew from California? Okay? Now, you guys got any idea how I was literally bowled over when I got an email from Carolyn sitting here saying, we've got 9 people coming from the University of California, Irvine. And I'm like, are you traveling 3,000 miles across the country just to come for this? I was like, okay. So thank you all very much for coming. Is there anyone else who's coming from far?
Massachusetts.
I got somebody here from Montreal. Okay? Oh my God. He crossed the border. Okay?
We heard Massachusetts.
We heard Massachusetts. Thank you. Oh, Seattle. Oh my God, welcome. Thank you. Anybody else?
Where are you from?
Bolivia. Oh, no, I don't believe that. Welcome.
Someone is tweeting this.
So let me just pass this mic to a couple of the co-leaders of various teams. So like Liz and Chris are co-leaders of the programming, so they helped put the program together. David worked on the operations, kind of like putting all the operations together. So let them tell you what it was like for them to put this conference together, and let them extend their welcome to you.
Good morning, everybody. David Matthews. I chaired the operations committee along with another wonderful person named Kristen, who's been helping everybody else at the front desk there. But I also sit on the board of directors of DBGM, and DBGM stands for Depressed Black Gay Men. It's critical, right, that we recognize that this is who we are talking about, especially that's who we are talking about here in this effort, right? For oh so long, black identified, gay identified men have gone without the support that they've needed for a very, very long time. And we see the results of that, right? We see a lot of the health disparity. We see what's happening with HIV and AIDS. We're seeing what's happening with violence and impoverished situations, right? And so Antoine Craig, well, for him, this has been his baby for 5 going on 6 years now, if not longer, right? And what's critical about that, though, is that once he got started doing this, he never stopped. He's been energetic and very motivated, and coming from a very empowered and unapologetic space about this effort. And so Antoine's been talking about it over the years, and finally snagged me as a board member. And glad to say that this is the first conference that I've been worked on as planning, and it's been difficult. One of the primary reasons why it's been so difficult is because you find out when depressed black gay men is the priority of an event, that all of a sudden people are prioritizing other things, right? Folks just do not see black men, they don't see gay men, they don't see black gay men for sure, right? And so when you're trying to find funds, right, when you're trying to get people to commit to a process, even if you are a black gay man, sometimes you just can't prioritize your own self in this situation in order to make this very vital event take place. So I'm so glad that we are sold out, so glad to see this room very, very filled, so gleeful that there are a lot of very interested people here. Not from a kind of, ooh, you know, what's going on here kind of perspective, like this kind of inquisitive kind of approach. But what I feel is that there are a lot of people here who, wherever you are, wherever it is that you're coming from, know that there's a significant situation going on and that you want to be able to learn some stuff to provide that kind of support. This is not about some kind of strange inquisitiveness. This is about creating actual change for a community that really, really needs it. Finally, I say thank you.
Once again, my name is Chris Adams. First of all, I'd like to say I want to thank Antoine for the work he's doing. And the other thing, working with this group of people, he's able to assemble some great minds, some great leaders. And I told Antoine a couple of times as we spoke that the people he assembled were really serious and interested and professionals. The other thing is that, and very important, we assembled some of the greatest minds in this rooms of health professionals and mental health professionals and people who want to learn about the LGBT community and regarding mental health. For me, this has been a great experience. Like I said, this is my second year doing this. Antoine and myself, we talk a lot, we fight a lot, we get mad at each other, but we come back together and do the work that's needed. So I would like to thank the team that he assembled, because organization is hard, volunteering is hard, getting people together to do things is very hard, but he has the tenacity, the will, and the strength to keep going. I don't know how he does it sometimes, but he does.
Hi, I'm Liz Margulies. I am a psychotherapist in private practice and the founder and executive director of the National LGBT Cancer Network. And I hate conference planning. Let me be clear, I hate it. I am here, and I've been here from the beginning because I would do anything for Antoine. He is an indefatigable leader and an inspiration. And I just want to add to what David said, which is this conference is not just about Black gay men, but the entire LGBT community of people of color. And the other part that really thrills me about today is the bringing together of consumers and community and clinical people, because there has been a tendency to keep these two communities separate. And we worked hard to create a meeting of these two worlds that rarely collide, let alone collaborate. So we have great plans for the future to come out of today. Thank you.
And I'd just like to invite Denis to give us a few words.
Good morning, everyone, and thank you. I first want to obviously thank Antoine, Liz, Chris, and David, and the great team of volunteers who really made this event happen. As you may know already, October 4th through the 10th of this year marks the National Mental Illness Awareness Week. How fitting and timely this first ever one day, in my mind, a LGBT people of color mental health conference is. And the theme, examining our challenges, healing our strengths, much can be celebrated and said about this. Again, I am Denis Romero. I serve as the Regional Administrator for the Substance Abuse and Mental Health Services Administration of the U.S. Department of Health and Human Services. Region 2, which is how we divide the nation into 10 regions. Region 2 consists of the states of New York, New Jersey, Puerto Rico, and the U.S. Virgin Islands. And as representing SAMHSA here, our mission is very simple: to reduce the impact of substance abuse and mental illness across America's communities. And how we operationalize this is by strengthening and providing leadership and devoting our resources towards helping the nation act on the knowledge of 4 basic principles. Behavioral health is essential to health. Prevention is effective. Treatment works. And people do recover. we know that the LGBT population experiences a wide range of health disparities across the lifespan. In particular, I want to point out that the sources such as the Institutes of Medicine have found that the LGBT disproportionately smoke, are obese, experience abuse and violence, have negative behavioral health consequences, and are more likely to become HIV positive. That we know. Of course, these health disparities have to be read in context, which is sometimes missed by the general population. Not everyone fits that picture. The resiliency of the LGBT community is something that is not celebrated enough. And frankly, these health disparities do have to be read in context, which is that the LGBT people are also disproportionately likely to live in poverty, to be uninsured, to face substantial barriers to quality of health care, including refusal of care, substandard care, inequitable policies and practices, and exclusion from health outreach and education. So we see that they experience some real challenges, but it is because of these reasonings that SAMHSA in particular has established the Office of Behavioral Health Equity, which is a specific office within the Substance Abuse and Mental Health Services Administration to focus on these specific LGBT issues. And so we have established a toolkit that's particularly geared towards professional providers, health providers, social workers, counselors, to really teach them how to work with them. So finally, I just want to remind you that the LGBT community have very unique behavioral health conditions that affect. The top issues are three, very simple: prescription drug abuse, suicide, HIV, mental health, and believe it or not, the challenges of aging. So I am excited to be here today, and I wish you all much success, safe travels for those who have come here for a long way, and I cannot thank you enough for have the opportunity to be here with you. Thank you.
And I'd like now to introduce to you Dr. Kenneth Ashley, who is, as you will notice in your program, is an assistant professor of psychiatry in the clinician-educated track at the Icahn School of Medicine at Mount-Sinai, an attending psychiatrist in the Division of Consultation, Liaison Psychiatry, and Psychosomatic Medicine at Mount-Sinai, Beth Israel, and the Director of Mental Health Services at the Peter Kruger Center for Immunological Disorders, also at Mount-Sinai. Dr. Ashley has been active in numerous mental health organizations, where much of his work has been focused on addressing health disparities and health equity for people of color, LGBT populations, and HIV. He has written, presented on mental health issues in HIV and cultural diversity, including LGBT issues nationally and internationally. Ladies and gentlemen, I have the honor to introduce you to our first speaker, Dr. Kenneth Ashley.
So I want to welcome you here to Mount-Sinai, Beth Israel. As Antoine told you, I'm here working in the HIV clinic, which is my kind of day-to-day activity here, but also active on the LGBT resource, employee resource committee here, and a member of the Diversity Council here at Mount-Sinai, Beth Israel, which is one of the sponsors of today's event. My slide set didn't load, which is fine. Don't have a whole lot of slides. Just want to talk about a couple of issues that I think you guys are going to be talking about over the course of the day. A little bit of an introduction. So, talking about the topic. The title of my talk is "Making Black Lives Matter and Making Things Get Better for the LGBT Community." And so I'm going to talk a little bit about some of the things that we see coming in ways that are going to actually really make things better and help the entire LGBT community in terms of their mental health care. So one of the first things I want to talk about, Mr. Romero has already hit a bunch of these things already, but one of the things I want to talk about is access to care. So the Affordable Care Act increased the number of people that are insured, which in and of itself should allow any number of people access to mental health care. some issues we're facing still have to do with some aspects of parity, meaning that not all health plans cover mental health issues or addiction services equally, but we're working on getting that addressed. But so many more people with insurance, a lot more access to care. So I think that that is one really positive thing. Associated with that, the federal government has rolled out a lot of initiatives addressing actually some disparities in healthcare for the LGBT community. Early on, the Obama administration made sure that whomever was in the hospital could choose who could visit them, because until that time, if you were not a designated family member as determined by some very kind of old policies, you might not be able to visit your family member. The issue of marriage equality has rolled out, and that has probably going to also increase the number of people with medical insurance through their partners or their spouses. The other things that have been rolling out, Joint Commission, which is an agency that accredits hospitals, one of the things they've rolled out a couple years ago is a field guide for providing appropriate services to the LGBT community. So we're seeing a lot of places, federal agencies, governmental agencies, kind of national organizations looking at LGBT health disparities and issues and trying to address them. SAMHSA has a great guidebook to help people. It's downloadable, free of charge. So, to go to the SAMHSA website and take a look at that. The other thing that the government is rolling out, or has asked, is for better data collection. Right now, a lot of what we're talking about here, small research studies, not a lot of good data. We're inferring a lot of the information from other studies about other communities, and so what we want to do is get really good data so we will be able to provide really targeted, appropriate services to all comers, whether they be LGBT, people of various cultural and ethnic groups, but anyone. So we want to get better services, better treatments, more targeted care, and so with ideally better outcomes. The other thing, a lot of governmental agencies are now paying for trans-related care, and so we're seeing a lot more people coming in for services around that, surgeries and things that are now covered by Medicaid and Medicare, and so once again, improved access to care, ideally improved outcomes for treatment of gender dysphoria, and so it's just the forefront of that, but hopefully as moving forward, we'll see a lot more people in care around those issues. Okay, so the issues are becoming available, the care is becoming available. People who have insurance. So the question is, how are we going to get people into care? So there are some concerns. There's some data showing that there are higher rates of stigma in both LGBT communities as well as communities of color. People present later for treatment. People are less likely to access services, and so we need to really, and we're not sure how we're going to do this, but certainly the word is being spread that services are available, trying to destigmatize mental illness in all communities, but particularly LGBT communities and communities of color. The other thing, so you have insurance, you want to go get treatment, how can you get good treatment? So we need to talk about the aspect of cultural humility or cultural competence. I have some concerns about the term cultural competence. We use it a lot, but that a lot of people think that they can sit in a room like this for a day and hear a couple of lectures and they're suddenly culturally competent. I think the idea of cultural humility speaks more to the idea that you're trying to learn some of these techniques, some facts about different cultural groups, and trying to take that information and apply it appropriately, but also recognizing that there's no way you are going to know all of the information about any culture, and you need to be open to the idea that you may not have this information. Learn from your patients, learn from what's around you, but recognizing that this is a kind of ongoing, constant issue that needs to be addressed in your practice as a provider. So I think you're going to hear a lot of lectures today about some aspects of cultural competence. I looked at the program, and so I'm glad to see that that's there. The other thing I mentioned, that is very, very important, is this idea of improved data collection and research. One of the things we are doing here at Mount Sinai Beth Israel is rolling out some new forms so people can actually find themselves on the boxes to check. I mean, how difficult is it for you to go into a doctor's office or a provider's office and see that you are nowhere recognized on their kind of intake form? What do? It's like you kind of write whatever you want in, but it may feel unwelcoming, and some people may actually walk out at that point because they feel like they're not welcome. With better data, better research, as I mentioned earlier, we will be able to probably we'll be able to track outcomes with different treatments and then provide better, more targeted care for clients, patients, whoever is coming in. And I think that's really important. So all you people in the room, it sounds like there's a bunch of students here. So hopefully there will be some topics here that inspire you, but research. It's great for your career. It's great for your patients. So think about it. I mean, you're here shows that you have some interest, and so I expect great things from all of you. The other thing I want to talk about that was also already touched on, HIV, medical comorbidities, disparities of health in the LGBT and people amongst people of color. Smoking, cannot overemphasize the deleterious effects of smoking. We've got Liz here from the LGBT Cancer Network. Sorry. Smoking impacts, of course, cancer in a number of ways, and it impacts health in a number of other ways. We see that particularly young LGBT folk are smoking more than their heterosexual counterparts, and in some communities of color, there are higher rates of smoking as well. HIV was already mentioned. The rates of HIV infection amongst young MSMs, particularly young MSMs of color, is, that's kind of what's driving up the kind of increased rates amongst MSM. The rates of new infections have remained stable at about 50,000 a year. Got a lot of interventions that we have rolled out recently. Pre-exposure prophylaxis, we need to get out there. We need to get people on it. We need to get people tested on medication because it does work. Some other medical comorbidities, obesity, hypertension, a lot of the chronic medical illnesses that people are facing are higher in communities of color. Not so sure what the data looks like amongst LGBT folk. I mean, and I don't want to make LGBT or communities of color this monolithic group, because within each of those groups there are very different subsets and populations to look at. And once again, we need more data to know how to provide more targeted treatments to provide better outcomes. And I was going to talk a little bit about institutional racism and anti-LGBT bias. I mean, that's the topic that I see on a slide, and I kind of groan like, oh my God, what can I do about that? How am I going to address something as large as institutional bias? Well, I mean, I think we can all, in our own little way, step up at that moment and make some comment that's appropriate, even though you feel that feeling in your stomach and you don't want to say anything, but every now and then you need to kind of step out and make a comment and kind of bring everyone, at least make them aware that this could be an issue going on in the room. It could be an issue. A lot of people, oh my God, what are you going to do about it? So, with the spate of recent killings of Black and African American men by governmental officials, I mean, it cannot help but impact on the mental health of communities of color. The recent, not even recent, but the kind of chronic killing and murdering of trans women, particularly trans women of color, it cannot help but impact on these communities as well. So we need to try to put in place increased awareness policies to combat the effects of the violence and the actual violent events. And lastly, but not leastly, I think to end on a positive note, in spite of all these negative things, the communities are very resilient, and we need to really find out what those things are, to put those things in place to help make sure that our community, to focus on the positive, to find out, okay, so if we do if we enroll people in this kind of group therapy aspect, they are going to be much better in terms of dealing with X, Y, or Z. If there's this medication that can be provided, or if this activity that can be provided, we need to really look at aspects that will improve outcomes, that will provide resilience, because once again, we're here, we're surviving, we're doing pretty damn well in spite with all the things we're dealing with. And with that, I'm not even sure what my time was, but I probably ran over. I just want to say, where is Antoine? Oh, you guys are going to break now. So, oh, okay, so that's it for me. I was going to flash my email address if people had questions or comments, but I can give it to you. It's fairly easy. It's kashley@chpnet.org. So if anyone wants to email me, has questions, has thoughts about research, whatever. Oh, so slowly, okay. HLEY@chpnet.org. And so once again, you guys should be networking here, making plans for next year's conference, because I want to see you all here doing presentations, and I hope we're going to be in a bigger space with, you know, much larger group. So thank you for coming. Have a great day.